that is the key. Excuse me. Because what this testing is designed to do at the start is eliminate the patients that we think will get respiratory failure postoperatively and say these are not fit for surgery. So a few other things, as I mentioned, people who have lung surgery are often smokers, and they often have pre-existing pulmonary disease, and that increases the risk of most of these complications. So as we know, if you have already some chronic lung disease, chronic bronchitis, emphysema, your risk of pneumonia, pulmonary embolism, respiratory failure is higher than someone with healthy lungs. And if you're a smoker, you have a higher risk of lung complications. If you're obese, you have a higher risk of lung complications. If you're elderly, so over 60, you have, not that over 60 is elderly, because I know Dr. Hafez is listening, but over the age of 60, and I'll talk about that in a second, we're at greater risk of atelectasis. And then the other things that increase your risk of complications are the duration of the surgery. So if you have a general anesthetic for more than 3 hours, that increases your risk. And that comes back to when I was talking last time about how we get atelectasis and gradual collapse with ventilation. The longer the surgery goes on, the more we stress the lungs with ventilation, the more atelectasis we get. And also the surgical site increases your risk of these pulmonary complications. So thoracic surgery, upper abdominal surgery, for obvious reasons, are going to increase your risk of pulmonary complications. And so most of our patients having lung surgery have pre-existing pulmonary disease. A lot of them smoke. Some of them may be obese. They've got this high-risk surgical site. A lot of them are over 60. And some of these cases take longer than 3 hours. So we're looking at the perfect storm for patients to get pulmonary complications. Now, the reason I said advancing age can increase your risk of atelectasis is the concept of closing capacity. So those of you that remember your physiology, the concept of closing capacity is that as your alveoli, when you breathe in and out at normal tidal breathing, your alveoli shouldn't normally collapse, and it's an independent intrinsic property of your lungs as to what lung volume, like what functional residual capacity they need before they start to collapse. And as we get older, the functional residual capacity at which they start to collapse gets higher, meaning that at just normal tidal breathing, you will start to get atelectasis once you get really old, like over 70 or 80. You can start to get some atelectasis with normal tidal breathing. And that's thought to be one of the reasons why when you do a blood gas, your partial pressure of oxygen is less in a person who's 80 years old than it is in a person who's 20 years old, because that 80-year-old already has some atelectasis and a little bit of shunting going on in their lungs. And that's one reason why. So older people are already prone to getting atelectasis. You add surgery, you add a thoracotomy, you add lung resection, and these patients are, by just for all these reasons, higher risk of complications, and we need to be more careful in our assessment of these patients. And obviously, obesity reduces your functional residual capacity because the adipose tissue pushes on your lungs, especially when you're supine, and causes gradual collapse. It also increases work of breathing, and when patients are a bit weak after having an anesthetic and a prolonged intubation and they have some pain from surgery, they tend to hyperventilate, and the obesity adds to that. And we know obese people are more likely to get a pulmonary embolus. So if you're going to have lung surgery, don't get fat and don't smoke. So I talked about, just coming back, functional capacity over here on the history. Now, I'm going to talk about how we define functional capacity on this slide, and then I'm going to talk about what they call the three legs or the three branches of preoperative pulmonary assessment. There's a very good article on this by Dr. Peter Slinger. If you Google Peter Slinger and three-legged stool, he talks about this in an article if you want more details. But hopefully today it will give you a good understanding. So I'm sure you're all familiar with the term MET, or metabolic equivalent. And that's just a way we measure the energy cost of various physical activities, and it allows us to give a quantitative assessment of a patient's exercise tolerance or functional capacity. And we use it for cardiac patients. You've probably used it for cardiac functional capacity. We also use it for respiratory capacity. And it essentially expresses how much aerobic demand a person can tolerate. One MET, or one metabolic equivalent, is 3.5 mils per kilogram per minute of oxygen consumption. So in a resting adult, that's our normal oxygen consumption is 70, in a normal 70 kilo adult, it's 250 mils per minute. I'm sure you will remember that from your physiology study. So patients with cardiac and respiratory disease have reduced number of METs. For cardiac patients, we talk about more than 4 MET being low risk. Patients with exercise capacity of less than 4 MET for cardiac with cardiac disease are considered high risk, and 4 to 5 to 9 METs intermediate risk, and greater than 9 METs low risk. And for respiratory, it's a sort of a similar number. So I'll come back to that. These 3 points here are the three-pronged or the three-legged approach to assessing respiratory function. So we have respiratory mechanics, gas exchange, and functional capacity, or also called cardiopulmonary reserve. The way I remember it is respiratory mechanics is the lung expanding and inhalation and exhalation, and that's getting the oxygen into the lungs. The oxygen's then got to get from the lungs into the alveoli. That's gas exchange. And then the oxygen's got to get from the alveoli to the tissues, and that is cardiopulmonary reserve or functional capacity, because that looks not just at your lungs but also at your cardiac capacity to shift that oxygen. Now, cardiopulmonary reserve testing isn't going to tell you whether it's your heart or your lungs that have problems if it's abnormal, but it just gives you a global index of that something is not right. So functional capacity, as I said earlier, I think is one of the most important of those three, because like I said, if someone's got great test results but you're looking at them and they look terrible and they're just out of breath sitting in the chair, you'd be a brave anaesthetist to agree to him or her having a pneumonectomy, for example. So I think it's very valuable. Conversely, if they have terrible tests but you've seen them walk and their functional capacity is good, then this may be a candidate who may survive the surgery. So the most common test I think used is the 6-minute walk test, and that basically measures how far the patient can walk in 6 minutes on a flat surface. So it shouldn't be in hills or anything. It's just a flat surface. They walk as far as they can in 6 minutes, and you measure the distance and you monitor the pulse oximetry at the same time. And like I was saying before, it just evaluates the global response to exercise, heart and lungs. And usually they compare the distance to normal age-matched control. So you compare a 30-year-old man with an age-matched 30-year-old man, a 50-year-old woman with what a healthy 50-year-old woman could walk, and you'll get a percentage of predicted. Normal is 400 to 700 meters. Usually we say about 610 meters is equivalent to, I think, 5 MET. I think that's on the next slide. If they desaturate more than 4%, that's a bad prognostic sign. And gold standard. So just coming back to this. This test is a functional test, and it's cheap and easy to do. You just need a pulse oximeter, a stopwatch, and have a rough idea of the distance they can walk. Formal testing, they do something called VO2 max, which is the oxygen consumption in kilograms, mils of oxygen per kilogram per minute. This is the gold standard functional capacity testing or cardiopulmonary reserve testing, but you need a formal exercise laboratory. So that's when they put someone on a exercise bicycle or a treadmill, and they stick something in their mouth and they get them to breathe and they work out the oxygen consumption. And obviously this is very expensive, and most hospitals can't do this. So this is why we do the 6-minute walk test. But when you do a formal VO2 max, 15 mils per kilogram per minute is considered the cutoff for what is low risk and what is high risk. So if the patient can achieve a VO2 max of more than 15 mils of oxygen per kilogram per minute, they have a low morbidity and mortality. Conversely, if they achieve less than 10, they have a high mortality. And the 15 corresponds to 600 meters on a 6-minute walk test. And as you can see, 1 met is 3.5, so 15 is 4 to 5 mets. So it's similar to what we want patients to achieve for cardiac risk. And it's kind of like a stress test, essentially. So the number in red there is the one I guess I want you guys to remember. A 6-minute walk test less than 610 meters means they've got a VO2 max of less than 15, and they're therefore high risk. Now, I should point out that if the patient has asthma or has emphysema or has some sort of lung disease for which they take their medication, you want to do this test after they've taken their medication. You get them optimized, get them as best possible condition as you can, and then get them to do the test. Because on the day of the surgery, that's what we would do. We would give them their Ventolin and so on and optimize them. So less than 10 is bad, more than 15 is good. An estimated predicted postoperative VO2 max less than 10 may be an absolute contraindication to lung resection, okay? And I'll talk a bit more later about a few exceptions to that, but for the most part, if they can't achieve 10, we're not going to let anyone operate on them. The highest VO2 max, I believe, used to be Lance Armstrong, the Tour de France cyclist, which was around 75 mils per kilo per minute of oxygen. Although I have been told there has been higher recorded, but I'm never sure if these guys are taking performance-enhancing drugs or that's just natural. So sometimes we can't do a 6-minute walk test. What alternatives can we do? Well, you can get someone to climb stairs, okay? Maybe your hospital doesn't have 600 meters of concrete to make someone walk on, but most places have stairs. So you can get them to climb stairs. Again, when we talk about cardiac patients for 4 mets, we talk about 2 flights of stairs. For respiratory, we say 3 flights of stairs usually, and 3 flights of stairs is equivalent to 20 mils per kilo per minute. So if your patient can achieve 3 flights of stairs, and that's 3 flights without stopping and without dropping dead, then they can get to 20 mils per kilo per minute, and they're low risk. If they can't even do 2 flights of stairs, they're high risk. If they do 2.5 flights of stairs, then you might want to look at their other tests and work out, okay, what else is going on. Sorry, I said Lance Armstrong was 75. It's 85 mils. Okay, so that's like a lot more than our lung patients. And these numbers, flight of stairs, you could say, well, how do I know what's a normal flight of stairs? So they talk about 20 steps with a 6-inch distance between the steps. 6 inches, 2.5 centimeters per inch for those of you like me who are metric people. So that's roughly what your stairs should be. So essentially then, to assess functional capacity is either a 6-minute walk test plus or minus a stair climb, or one or the other. So that's a good way of assessing the patient's functional capacity, and it's an easy way to do. And if you have you're seeing them in the clinic, often you can just pop out to the stairs near the clinic and walk with the patient and watch them. So the other 2 legs I mentioned are spirometry and gas exchange. Spirometry, or pulmonary function testing, excuse me, is a very simple bedside test if you have the equipment to do it. Now, big hospitals will often have a laboratory where they have a trained technician who does the testing, and that's a lot more accurate. But I've worked in hospitals where we don't have that, but we just have a small little machine where you basically get the patient to blow into the machine, the FEV1 or forced expiratory volume, you get them to do a forced vital capacity breath. So breathe in, breathe out as hard and for as long as they can. And then the machine will calculate the FEV1, which is the forced expiratory volume in 1 second, and the FEV1 over FVC ratio, okay? And then the gas exchange, the DLCO, is also considered part of spirometry, but you need a bit more sophisticated equipment to do that. And then you can plot the flow volume loop. And often the good machines will do that for the spirometry. And I'll talk briefly about that, but without going into too much detail. This is just a recap of some of the terms. Those of you guys who've read physiology should remember this, but obviously we're talking about the lung. This is the total lung capacity, which for an average adult might be 5 liters. Tidal volume is the breathing we do just when we're resting and when we're not trying to breathe, we just breathe in and out. And the functional residual capacity is what's remaining in the lung at the end of a normal tidal breath. If we do a vital capacity breath and empty our lung as much as we can, which is what we do for the FVC, that's this yellow here, what's left in the lung is the residual volume. And then there's these inspiratory capacity, expiratory reserve volume, and all of these terms, which I won't go into in too much detail. Suffice to say, though, in chronic lung disease with emphysema, your residual volume increases, your functional residual capacity increases, and in restrictive lung disease like pulmonary fibrosis, they decrease. And so that affects the test results. So, as I mentioned, FEV1, that's the definition there. And when you get the result, it's usually going to be an absolute value in liters and a percentage of predicted compared to age, sex, and height matched controls. Height matched is kind of important because obviously if you're 6'2", you're going to have a much bigger FEV1 than someone who's 4'8", and so you can't compare the two. So there are actual tables. When I was an intern, we used to have this little book attached to the machine. We'd reel it around, get people to blow into it, and then we would look in the book to see what their matched was and calculate the percent predicted. We can talk in absolute numbers, and an example is in a man, more than 3 liters would be normal, and in a woman, more than 2 liters would be normal. But most of the literature and the guidelines talk about percentage of predicted, which I think is a little more helpful because obviously people are different heights and different ages. And if I don't know, I can't remember what's normal, but I know if someone's 100% predicted, then it's obviously normal. As I mentioned, the volumes change in chronic lung disease. So in COPD, although your residual volume and FRC increase, your FEV1 falls quite significantly, and your FEV1 over FVC ratio is actually low. And with chronic lung disease, your FEV1, pulmonary fibrosis, restrictive lung disease, your FEV1 over FVC ratio increases, and I'm sure you're all aware of that. So as a general rule of thumb, if they have less than 50% predicted FEV1, they're what we call in Australia a dodgy patient. They have bad lungs and they're going to cause us trouble. If they have an FEV1 of less than 1 liter, that's very severe disease, and most people would say less than 1 liter is an absolute contraindication to pneumonectomy, because if they've only got one liter and you take out half their lung, then they're not going to do very well. Again, there may be an exception or two to that, and I'll talk about that later. And the peak expiratory flow rate, which is a very simple machine, and they're very cheap, and they're not as complicated as a spirometry machine, we use for asthma, and the normal number is more than 200 liters per minute. But that is also considered a spirometry test. So the normal ratio, FEV1 to FVC, is 0.7 to 1. As I mentioned, in COPD, this changes. So in emphysema, FVC increases, your FEV1 decreases, so your ratio decreases. And in restrictive lung disease, your FVC decreases, so your ratio increases. So the hallmark of spirometry in obstructive lung disease is an FEV1 over FVC ratio less than 0.7. And in restrictive lung disease, it's more than 0.7. But remember, normal is also more than 0.7. As I mentioned, we want our patients to take their bronchodilators if they're normally on them. And patients with asthma or emphysema may get some improvement in the FEV1 with bronchodilator therapy. So if your patient for preoperative assessment has really poor FEV1 and they normally take bronchodilators, make sure they've had their bronchodilator and repeat the test if they haven't. So bronchodilators can help patients with emphysema, but they're more effective in asthma. So this is a normal flow volume curve. I'm hoping it's not new to most of you and you've seen this before. The volume is here. When the patient inspires or inhales, this is a zero volume. These curves are always kind of backwards. You get this loop, and then so the patient takes a maximal inhalation and you get this inspiratory limb. And then as they exhale and breathe out as hard as they can, hard and fast as they can, you get initially a really rapid outflow of air, and then it slows down. Okay, and this inspiratory limb is related to some degree to patient effort. Okay, if the patient is not doing the test properly, this won't be as hard as straight and fast as it should be. This is flow in liters per second, so the flow won't be as high. So this is somewhat effort dependent. So if the patient is sick or they're having they're sedated or hyperventilated or whatever, this may not be so accurate, and the test you may not be able to interpret. And this part is effort independent, because this is when the airways take over. No matter how hard you blow, this is to do with the intrinsic properties of your bronchi. And so this part is determined by your lungs and your lung elastic recoil. So if you have impaired lung elastic recoil, which is what happens in obstructive lung disease, particularly emphysema, you can still maybe generate a decent flow, but probably not as good as someone with normal lungs. But then you see this just fizzles out here like a car with no petrol. It has a big concavity. So you can still get a good breath, and then this is classic, like scalloped appearance or convex appearance is obstructive lung disease. And those of you who have more sophisticated ventilators on your anesthesia machines or in intensive cares, often they plot these curves, and you can see if your patient is doing this on the curve, then you know they have chronic lung disease. And I haven't got one here, but if you do the same test with restrictive lung disease, it looks something like my arrows tracing here. They won't have as big a volume, so it comes out smaller, and then it's sort of almost concave because the elastic recoil is abnormally increased. So that's just an example. I think you're probably going to have some more lectures on this with your physiology, but you may get one of these printouts on a spirometry report, and I find that useful because without even looking at the numbers, if you look at this, you know your patient has impaired lungs. Or if you get a picture like this, you're thinking, this looks okay actually, as long as the volumes are around normal. But the percent predicted is the most useful. So we have 20 lung segments on the left, and I think 22 lung segments on the right. I've got to be honest with you, I could never remember how many lung segments there were, but the reason it's useful to have a rough idea, and the reason the lung is slightly more is because the lung has the middle lobe. I think I learnt the lung segments maybe for my Part 2 exam and promptly forgot them all, but it's kind of important if the surgeon says he's doing a segmentectomy or he's doing a lobectomy, because if he's doing a left upper lobectomy, you're going to lose 10 segments. If he's doing a right upper lobectomy, you're going to lose 6 segments. And the reason that's somewhat important is there's this concept of predicted postoperative FEV1 or predicted postoperative VO2 max. And by predicted postoperative, what they mean is when the patient has had some lung taken out, what do we predict their FEV1 to be after the surgery? What do we predict their functional capacity to be after the surgery? And that's really important because somebody might have good lung function or reasonable lung function or reasonable FEV1 before the surgery, but if you go and take out 10 of their segments, you can see that's almost a quarter of their lung function. We should try and calculate, if we can, what's left, because maybe they're doing okay with those 10 segments, but we take them out and then they're really struggling. So sometimes we calculate the predicted postoperative FEV1 and we think we have to say, actually, no, this guy can't tolerate losing 10 segments. So you can try and haggle with your surgeon and say, could you only take out 8 segments? But most of the time, the surgeons will take out what they need to take out, but sometimes they're going to have to take the whole lobe or the whole lung, and then if they can't reduce their resection, then the patient may not be fit for surgery. The other thing I should note is that if they're doing a pneumonectomy, it's a much easier operation. You've got your trachea, the surgeon just cuts the trachea, cuts the blood supply, and takes the lung out. The less they take out, the longer and more complicated it takes. So if they're doing a segmentectomy, that can take, depending on how good the surgeon is and how fast they are, can take 3 hours sometimes, 4 hours, and especially if they're doing multiple segments. So remember at the start we said the longer the operation goes on, the more the risk of postoperative complications. Sometimes it may not be in the patient's best interest to do multiple segmentectomies instead of, say, a lobectomy or pneumonectomy, if they can tolerate it from a capacity point of view. But the reason I have this slide here is just to give you a rough idea of the number of segments to help us calculate the predicted postoperative FEV1. So these numbers in red are just rough percentages. So this is what I kind of carry around in my notepad, is that left upper lobe 23%, left lower 23%, 14, 10, 30. So when I'm working out predicted postoperative FEV1, I'm using this equation here. So the predicted postoperative FEV1 is my pre-op FEV1. So remember we said we'll get a percentage FEV1 compared to what's normal. And then we take the percentage of lung remaining and we multiply that by the pre-op FEV1 and we divide it by 100. So for example, if we have a patient having a left lower lobectomy and their preoperative FEV1 was 70% predicted, so we go back and we say, okay, he's having a left lower lobectomy, he's having this bit taken out, 10 segments, it's 23% of his lung. Now he was 70% to start with, okay? So we take our 70% or 0.7 times 1 minus 0.23 because we want to know what he's got left. So he's got left 77% of his 70% to begin with, which gives us 54%. Does that make sense to everyone? I'll just pause, give people a minute if they want to read those 2 lines while I have a drink of water, and if anyone has any questions about that, because it's kind of nice to know. I'd like to say I've used this many times to cancel patients, but the reality is I haven't. I've often seen a patient on the table and the surgeon's already started operating, and I'm looking through the notes trying to work out if this has been done, or I've worked it out myself, and by the time he's in the chest, it's too late to go, oh dear, the predicted post-op FEV1 is really low. But I'll give you guys a minute to look at that. Okay, no questions? All right, if you come up with anything, feel free to interrupt. Now, the next part of this slide is kind of important because, again, this stuff certainly in Australia comes up in the multiple choice exam, and also, as I was saying before, in the oral exam. If someone's having a discussion with you, you've got a woman or a man coming in for lung resection, and their pre-op FEV1 is 60%, and they're taking out their left lung. How are you going to assess whether or not they can tolerate the operation? And this slide will kind of hopefully help you make that decision. So predicted post-op FEV1 of more than 40% is considered a low-risk group for post-op respiratory complications and failure, whereas predicted post-op FEV1 of less than 30% is a really high-risk group. These people you will not be able to extubate. They did one study of 10 patients where they operated on predicted post-op FEV1 of less than 30%, and 6 out of 10 died. So pretty dodgy group of patients, and pretty high risk. So just remember those numbers: more than 40%, less than 30%. More than 40%, no worries. Less than 30%, no operation. And in between, that's when you look at the other tests. Okay, so if you think of preoperative pulmonary assessment as a bit of a cascade, it can be helpful. So what I mean by that is if you look at your first test, which is usually this one, predicted post-op FEV1, and if it's more than 40%, you might say, fine, I don't need any other tests. If it's less than 30%, you might say, I'm not sure we should be doing this. But I'll talk in a minute about other tests you could do. But for the most part, it's the patients that fall in between where you want to look at other tests. So the next test is the DLCO, which is the diffusing capacity of carbon monoxide. So this is where they essentially assessing the parenchymal function of the lungs, the ability of the lungs to exchange gas, and they use carbon monoxide to do it because carbon monoxide rapidly crosses the alveolar membrane into the bloodstream, and it gives a good indication of gas exchange. So they used to, before we had DLCO, they used to do blood gases, and as a general rule, a PO2 of 60 and a PCO2 above 45, over 45, less than 60 were signs of bad prognostic outcome, which you'd expect because these are marginal patients. But we can still do a gas, and look, it's not a waste of time, but I think people these days look more at these other tests like the DLCO. So it basically gives you an idea of how much of the alveolar capillary interface is still working, because if people who have got a lot of lung disease, sometimes the alveolar capillary interface is obviously damaged, and you want to get an idea of can they clear their CO2, can they absorb oxygen, and if I remove 23%, like the previous example, are they going to have enough functioning area to clear their normal gases? So the good news is the number you've got to remember is the same as for FEV1. So predicted post-op DLCO of 40%, or of less than 40%, I should say, is associated with increased complications. But if it's more than 40%, it's considered to be okay. But interestingly, that if their DLCO is less than 40%, even if they have a normal FEV1, they're considered to have a higher risk of cardiac and respiratory complications. Now, it doesn't mean you wouldn't operate on them. It just means that they're higher risk, and then you've got to look at everything else. So the FEV1, their functional capacity, which, again, we've talked about, their cardiac history, all their other things, right? Because if you have a marginal lung patient who then has a history of ischemic heart disease, hypertension, has had a bypass, and maybe gets occasional angina, you'd probably say not doing them. But if you had a marginal lung patient like this, but no cardiac disease, even maybe had an echo or had an angiogram for some reason, and they've got clear vessels, you might say, okay, we'll take the chance. So these patients that kind of have these high risk groups are not necessarily not going to be done, but we just need to investigate them more carefully. So this last point on the slide is talking about patients with a pre-op DLCO of less than 20%. So that's preoperatively. So that's before we're not talking about predicted post-op. We're just talking about before we've taken anything out, less than 20%. As you'd expect, they had a really high mortality. And there was this trial in America called the National Emphysema Treatment Trial, which it was a trial where they looked at patients with really bad emphysema and tried to see if there was operative interventions that could actually benefit these patients. And there's this type of surgery called lung volume reduction surgery where it's based on the theory that when you have bad emphysema, you get emphysematous bullae, which expand in your lungs. And some of the time, the bullae are so big, they're actually compressing what little remaining lung tissue, functional lung tissue you have left. And the theory is if the surgeon can get in and remove some of those big bullae that are not doing anything, the big bubbles, it can help what remaining normal lung tissue you have expand and work better. That's the theory. And we did a few of these when I was in Canada, and I dare say they're not done very much anymore because the mortality is very high, and it seems that the mortality benefit of those operations isn't very good. It doesn't seem to outweigh the risk, and there's less invasive things they can do now. So sometimes what they do, instead of operating, they stick in these valves, that's one-way valves where the bullae are, and that acts to sort of drain the air from the emphysematous segment without letting it re-expand. Kind of like if you ever buy a bag of coffee or something with a one-way valve, something like that they're sticking into these people's airways to help collapse these and do essentially the same thing as you do in lung volume reduction surgery, but more safely, arguably more safely. But the National Emphysema Treatment Trial, when I read that article, to me it was just staggering that someone is actually trying to find a way to make these patients who are not fit for anesthetics have an anesthetic. And obviously a lot of them died, and there was a very, very small subgroup who showed a survival benefit, but it was very small, and I think it's a little controversial as to whether we actually help these patients by operating on them. Having said that, as an anesthesia fellow, they're really fun to do because these patients are a hair away from dying, and so you're on your toes the whole time. So really interesting cases. Okay, so I'm just going to recap. This is the three-legged stool approach, or the three-pronged approach to respiratory assessment that I was talking about. So remember, the first step is getting the oxygen into the alveoli for pulmonary mechanics, and the FEV1 is the important test to remember. Predicted post-op FEV1 less than 40% is bad, high risk. Less than 30%, very high risk and not able to be extubated. And just to go back on that, any of you guys that have worked in intensive cares and have had patients with chronic lung disease that get intubated for whatever reason, you probably know that it can be very hard to extubate them. It can take days, sometimes weeks. And so if you've got someone with a predicted post-op FEV1 of 30% having lung resection, and you have to take them to ICU tubed, you know that they could be stuck there for like a week, and there's a whole host of other things that can go wrong: ventilator-acquired pneumonia, pulmonary embolus, all sorts of things. So really, we want a good reason if we're going to operate on someone like that, because we're putting them at very high risk of morbidity and mortality. So the next test, getting the oxygen from the alveoli into the bloodstream, parenchymal function, DLCO, predicted post-op less than 40% is the bad prognostic sign. And I've just got at the bottom, the gas numbers is just another bit of information that may or may not be helpful. And then cardiopulmonary reserve or functional capacity is the oxygen getting from the alveoli, the blood into the rest of the body, the tissues. And the number is 15 mils per kilo per minute, which, as we discussed, is equivalent to 3 flights of stairs or a 6-minute walk test of 610 meters or more. So those are the three things we look at. And I remember I said it's a cascade, so that if you have the FEV1 less than 40%, then you go, okay, well, what's their DLCO? If their DLCO is good, then and their functional capacity is good, then you might go, okay, look, this patient's probably going to be okay. If their DLCO is less than 40% as well, then you really want to see a good number here. And if this is less than 15, then you'd be very very reluctant to proceed. But we very rarely get this number, so we're always going with the stair climbing test or the 6-minute walk test. So in the real world, patients with the predicted post-op FEV1 of less than 40% comprise about 1/4 of for average thoracic surgical population, so 25% of our patients. So remember we said less than 30% we can't extubate, more than 40% will do well. The in-between group, most of them we should be able to get the tube out in the operating room, but they have to be warm, alert, and comfortable. And comfortable is really important, and I'll touch on that in my next talk I give you guys, which will be about anesthesia for thoracic surgery. The type of analgesic techniques we use in these patients, but if you have a good technique and you get them comfortable, it's really important with thoracic surgery because it's painful. They're big cuts. They're in the chest and they impair respiration in a group, as we discussed, which are already high risk for respiratory complications. Now, if they have a lot of pain and they don't breathe up, then the risk goes up. And now we're talking about, of that group, the 1/4 that are already marginal. Really important to have good analgesia. And in some of these patients, depending on where you work, the epidural is king and considered the best technique. Sometimes there's extrapleural catheters which can be done by the surgeon. Doesn't matter which technique, as long as your hospital is familiar with it, and we manage it not just in the operating room, but the first 2 to 3 post-operative days. Those are the really important areas. It's great to put an epidural in the operating room and wake the patient up comfortable and get the tube out and they look great. But if that epidural is not managed well that night, the next morning, or the day after that, they will get some atelectasis and pneumonia. So that's really important. So if the predicted post-op FEV1 is greater than 30% and the exercise tolerance and lung parenchymal function exceed the risk thresholds, then we should be able to extubate. That's basically the bottom line. And as I mentioned, we really want to extubate these patients. So what I will touch on now is the ventilation perfusion scan. This is a scan where you look at lung ventilation using a radioactive tracer and lung perfusion. And the most common time this scan is used is when you look for pulmonary embolus, and they look for ventilation perfusion mismatch. But you can sometimes do just a perfusion scan, which for lung surgery is quite useful, because sometimes the lung that is being taken out already doesn't have very much function because it's diseased lung, be it for tuberculosis or if it's got a big tumor or a big abscess or really whatever reason, but sometimes it's not contributing that much. So if you have a perfusion scan, you can sometimes get an idea of, because of hypoxic pulmonary vasoconstriction, that segment of lung may not be doing very much. So you can sometimes get reassured by a scan like this. So if you have going back to one of our patients we said was marginal, say you have a patient with a FEV1 of 1.5 liters. Remember we said less than a liter is usually considered an absolute contraindication. And they were having a left pneumonectomy, you'd be very worried. Or if it's like 50% predicted pre-op and you're taking out their left lung, that's 46%, you'd be very worried. But if you can get a perfusion scan and it shows that lung is contributing less than 10% of the patient's lung perfusion and function, then you'd be much more likely to proceed because you know, okay, we're going to take out the patient's left lung, but it's not really 46% we're taking out. It's like 10% or 5% or something like that. So it can be really useful in the group of patients that are marginal. So I guess what I'm saying is if they've got good FEV1, predicted post-op FEV1 and DLCO, you're going to proceed. If they've got really terrible, you're probably not. But if they're falling in between, then this is where a ventilation perfusion scan, or at least a perfusion scan, can be very helpful in helping you decide one way or the other. So this table is just showing what we just discussed, the 3 prongs: respiratory mechanics, FEV1, VO2 max and cardiopulmonary reserve, and assessment of parenchymal function. And just at the bottom is the article I mentioned by Peter Slinger, and it just goes into more detail about that. And this, again, is just part of that post-operative management plan. So if their predicted post-op FEV1 is more than 40%, we're aiming to extubate in the operating room as long as they're alert, warm, and comfortable. If it's 30 to 40%, we would still aim to extubate as long as they have good DLCO exercise capacity, and depending on what their perfusion scan showed about the lung function and what their comorbidities are. And if it's less than 30%, we can't extubate. We're going to have to ventilate, and we're going to probably wean mechanical ventilation. Okay, so that's pretty short topic, but it's a weeknight and we're all tired, so I didn't want to go on for too long. But are there any questions, or does anyone need anything clarified? It's pretty self-explanatory, but it's just once you've heard it once, hopefully you remember it